Hello, I'm Dr. Leonardo Claros. I'm the Chief of the Bariatric Surgical Division for the St. Luke's Health Network, and I'm also the Director for the Weight Management Center. It's my pleasure to welcome you to this informational seminar. If you're struggling with obesity, if you have developed conditions that are related to you being overweight or obese, know that you're not alone. Obesity is a huge pandemic, it's a huge problem, and is on the rise. Sadly, the US leads the way as one of the most obese nations in the world. And that is the reason why we're having this info seminar, because we want to tell you about a cure that will help you deal with your weight. You should know your BMI. This is a number, it's a ratio. The importance of knowing your BMI, which stands for body mass index, is that it's going to allow us to classify your degree of obesity. If you see on the slide that is depicting this, patients that have a BMI between 35 and 39.9 with an associated medical condition, they will qualify for surgery. That means that insurance will pay for it. On the other hand, if a patient has a BMI of 40 or greater, then just by number alone, they will qualify for this operation. This is very important because if you're interested in having a procedure done, but if your BMI is not within this range that the National Institute of Health has provided us to follow, well then you're not going to qualify for the operation. This slide depicts that 95% of our patients have a quality of life improvement after the operation. And furthermore, about 89% of them will see a significant reduction in the mortality. That means that the chance of dying as a result of any of the conditions that you have on this slide will be cut by 89% in just 5 years. So let's take a look at some of them. Migraines, 57% resolution. Depression, 47% reduction. Pseudotumor cerebri, 96% resolution. Obstructive sleep apnea, you know that noisy machine that you have to wear to sleep, there's a 74 to 98% chance of resolution. Hypercholesterolemia, 63%. Asthma, 69%. Hypertension, high blood pressure, 69% resolution. NASH, 90% resolution. Metabolic syndrome, 80% resolution. GERD, heartburn, that very uncomfortable sensation that you might have during the day or also at night, there's a 72% chance of resolution of that by losing weight with a bariatric operation. Incredibly, type 2 diabetes is one of the most amazing things that we can do with these operations. 82 to 98% of the patients will have either a significant improvement or even resolution of their diabetes. And that doesn't happen after weight loss. That can happen the day or 2 days after surgery. So it's not really related to the weight loss. It's something that happens with these operations that will significantly improve your diabetes. PCOS, infertility, stress incontinence, arthritis. We have a lot of patients that cannot even walk because of the weight. They need a hip replacement, a knee replacement, they need back surgery, and they are being told that they need to lose weight before their surgery is done. Come on over. Let's help you with the operation and you will see how amazingly well or better you're going to feel. Venous stasis disease, gout, the list goes on and on. The last time I checked, there were like several dozens of conditions that can significantly improve after the surgery. I'm just naming very few, some of the most important, but once again, this is absolutely amazing what we can do with the operation for you. So let's talk about who does not qualify for surgery at the hospital. If you have an ongoing drug or alcohol abuse problem, you do not qualify. You need to be sober, you need to be rehabbed, you need to be under control before you consider for an operation. If you have untreated or undertreated mental illnesses, psychosis, bulimia, nervous, if you have an eating disorder, then you're not a candidate for surgery. If you had any mental health inpatient admission to the hospital for any reason within the last 2 years, it does not disqualify you for surgery, but it will delay it. You need to demonstrate that you have been stable under therapy, under control, under medication, with a therapist, with a psychologist, before you are considered for an operation. On the other hand, if you have a diagnosis of schizophrenia, one of the clusters of schizophrenia or a personality disorder, that is a contraindication for this surgery. For my ladies, if you're pregnant or you're planning on becoming pregnant within 2 years, you should wait. Wait until the surgery is done. Wait for 2 years and your pregnancy is going to be much healthier, much better. You can have a normal, natural delivery, and if you need a C-section, it's going to be much safer and much better as well. If you have mental or cognitive impairment that will limit your ability to understand what is required from you after the surgery, then you shouldn't have it. It's a problem. It's one of the contraindications as well. Lastly, if you have an obesity related to an endocrine disorder, this is rare. If you have problems with your weight related essentially to a glandular problem, either your thyroid is not working well or your adrenal glands are working too well, well then you don't need surgery for that, you just need therapy. But your doctors most likely would have ruled that out with just some labs, and if they didn't do that, we will do it for you because you don't need an operation for that, you just need medical therapy. This is a very brief review of your digestive system. This is how your digestive system looks. We have the esophagus, the stomach, the small bowel, and the large bowel. We're gonna turn this into the two most commonly performed surgeries, not only in our center, but also in the United States. The one on the left is the sleeve gastrectomy, second best option. If you are in a BMI that is not that high, you don't have significant medical conditions, the BMI might work well for you. The one on the right is the Roux-en-Y gastric bypass. This is still pretty much the gold standard and has been practiced and has been performed since the 1960s. The technique has evolved. We do it much better, much faster, minimally invasive, tiny little incisions. Long gone are those days where patients had to stay in the hospital for about a week, where they had large incisions or anything else. Now we can do these operations very fast, like about an hour. Patients are walking that night and most of them are going home the next day. So let me explain to you how both of them work. Let's talk about the gastric bypass. The gastric bypass is a very effective, efficient, and durable operation. Both surgeries, the gastric bypass and the sleeve, are done exactly the same way. Laparoscopically, tiny little incisions. We put trocars in the abdomen of the patient and we actually turn attention into the stomach. For the gastric bypass, we're gonna make a small pouch, stapling the upper portion of the stomach. That's gonna be your pouch the size of a golf ball. Then we're gonna turn our attention to the intestine. We're gonna divide it. And that lower portion of the intestine that was divided, we're gonna swing it all the way up and we're gonna connect it to your pouch. We're gonna put stitches, staples, we're gonna make it watertight seal so nothing spills out. And then we're gonna measure about 6 feet and we're gonna reconnect that portion of bowel that was divided initially. And as you can see, you're gonna be able to eat only a small amount of food. That food is not gonna be digested and it goes all the way down and it mixes with the digestive enzymes and pancreatic juices. And that's why, because of this dual mechanism, this surgery works really well. For the sleeve gastrectomy, the process is pretty much exactly the same. There's no more anesthesia, less anesthesia, more incisions, less incisions, more vitamins, less vitamins. Everything is the same. The only thing that is different is what happens inside. But the approach is exactly the same as I said before. Laparoscopic instruments, trocars into the abdomen, and this time, instead of focusing on the upper portion of the stomach, we're gonna take a look at the entire stomach. We do not touch the lower intestine. A normal adult stomach holds about 2/3 of a gallon in terms of volume of food. That's how much food you can put into a normal stomach. For the sleeve gastrectomy, we're gonna reduce the size of the stomach. How do we do that? We staple the stomach all the way close to the pylorus up to your esophagus, and we remove about 80 to 85% of the stomach. It's gone. This operation is non-reversible, as opposed to the gastric bypass that you could potentially reverse. This operation will give you a long, thin stomach that is gonna fill with food much faster. You're not gonna be able to actually hold as much food as you did before. And it has a very strong metabolic component as well, because that portion of stomach that was removed holds this hormone or produces this hormone that will actually decrease your appetite. So just like it happens with a gastric bypass, the appetite is gonna go down. All I'm asking you to do is keep an open mind, read about both operations, come to the office, and when we are sitting face to face, we will tailor the treatment specifically to your needs and we will tell you what we think is going to work best for you. There's some possible complications. I have listed some of the complications in this slide. If anyone is telling you that surgery is risk-free, they're lying to you. It could be very safe, especially if it's done in a center of excellence like ours, especially if the surgeons are properly trained, bariatric, formally trained like all of us. If we have all the experience, all the equipment, a multidisciplinary team, we can minimize the chance of any of these complications happening. You should also be aware of possible side effects with the surgery, and I'm going to list some of the most common ones because these are commonly asked questions. The dumping syndrome. I have a lot of people that come and tell me, I don't want to have the gastric bypass because I do not want to have the dumping syndrome. You should know that dumping syndrome does not come from the surgery. it comes from patients not eating the way they're supposed to eat. So if you're properly trained, if you're properly educated, and you're being compliant, you do not have to worry about dumping syndrome. And also, you should know that dumping syndrome can also happen with a sleeve gastrectomy, but it's not as common. If you're successful. Temporary hair thinning. Some people say that, well, should I be concerned about, my hair falling off? All I have to tell you is keep up with your protein intake. During that stress phase that you're gonna be losing weight, you might lose some hair, but it grows back again. And we have all the nutritional counselors to help you go and, take care of all that. Nausea, vomiting comes usually from you not eating the way you're supposed to. You might be eating too fast, eating too much, not chewing properly, so we will teach you how to prevent that. They ask us about changes in bowel habits. Patients can become constipated. You're not gonna be able to drink as much or as fast as you did before. So if you're not properly being hydrated or keeping yourself hydrated, then without a question, you're probably gonna develop constipation. We're gonna teach you how to prevent that. They always ask us about excess skin. What's gonna happen if I lose a lot of weight? I'm gonna have a lot of excess skin. You're gonna have some excess skin. There's no question about that. 90% of our patients, they don't care. They feel so great. They have got rid of their diabetes, hypertension, cholesterol, their knees don't hurt anymore, their backs don't hurt anymore, they're walking, they're active, they're living life enormously and joyfully. So they don't really care about some redundant skin. If it becomes an issue or a problem, you can have a cosmetic surgeon remove it. Rarely these operations are covered by insurance because they're considered cosmetic surgeries, with very few exceptions. We can discuss more about this when you come to the office, and we can elaborate a little more on that. Last but not least are psychosocial implications. This is gonna be hard. Whomever is telling you that you're taking the easy way out, they have no idea how much you have to work at this. We will help you. We're here to help you. The program is designed to make sure that you're successful long term. So this is not an easy way out. Most of our patients, when we ask them, do you have any regrets? They're like, I only have one regret. I will do it tomorrow in a heartbeat. My only regret is I should have done it sooner.
I'm going to talk to you a little bit about our insurance and office process. The very first thing you want to be sure of is that you have the benefit for weight loss surgery with your insurance. Not all insurance plans cover weight loss surgery. I'm going to give you an example. Somebody could work for company A and have Capital Blue Cross. They may have the benefit for weight loss surgery. Somebody else could work for company B. They too use Capital Blue Cross as their insurance plan, but they may not have the benefit for weight loss surgery. So that's why it's important that you call your insurance company and make sure that you have the benefit. You can give them the code 43644, and they should be able to tell you, yes, you have the benefit, or no, it's an exclusion. The other thing you must have is the proper BMI, as Dr. Claros talked to you about earlier. So what does our program require? We do require that you have a dietary evaluation, a behavioral health evaluation. We do need you to come to one of our support groups prior to getting to surgery. We're going to need for you to have clearance from a cardiologist. It's possible you may need a sleep study. If you know you already have sleep apnea, it's not necessary for you to go through that process again. When you come into the office for your first visit, we will do a quick assessment to see if you are at risk for sleep apnea. If your risk is high, we will send you off for a consultation. You're going to need to get an EGD. That is when one of the surgeons would take a look in your stomach by using a scope. We're going to need a letter from your primary care physician. And we're going to need you to lose a little bit of weight before surgery. You will be working with our dietitians who will help you with that process. And if you use tobacco in any form, you're going to need to quit. This is for your safety. Some insurance companies may require more than St. Luke's weight management program requires. So how are you going to know what to do? Your first evaluation appointment is made convenient by having your dietitian and behavioral health evaluation done in one visit. This first visit is also free. You will also meet with the insurance specialist during this 3-hour visit. Your insurance specialist will provide and review with you a step-by-step checklist to get to surgery. Now I'm going to talk to you a little bit about finances. All out-of-pocket hospital expenses will need to be paid before surgery. There is no payment plan available. This does not include any cost for the surgeon or anesthesia, and this is also a best estimate and you may still get a bill. You would need to call your insurance company to have them tell you what your financial responsibility will be. You may have some deductibles, you may have co-pays or co-insurance. Please keep in mind the time of year, as when we move into a new year, that deductible may increase again. So why should you come to St. Luke's to have your bariatric surgery? First, all surgeons are board certified and they've all been fellowship trained in bariatrics. They perform thousands of procedures and have had excellent outcomes. And there's a very short hospital stay. Most patients will go home either the day after surgery or the second day after surgery. Our surgeons and our programs stay up to date with new technology. Our team has published in many professional journals and have been invited to present at national and international conferences. In addition to our surgeons, our nurses, dietitians, social workers, and physician assistants have years of experience caring for those who are suffering with the disease of obesity. We offer free follow-up care with our bariatric surgery dietitians and social workers. And some of our staff have had bariatric surgery and are more than willing to answer any questions you may have. We perform bariatric surgery at 3 locations. In order to better serve you, it's important that we match the office with the location of the surgery. If you would like to have surgery with Dr. Claros or Dr. Elchar, please call one of our 2 Allentown offices. If you would like to have surgery with Dr. Bariel or Dr. Akasoba, please call either our Monroe office or our Warren office. If you are ready to move forward with bariatric surgery at St. Luke's, complete and submit all the secure electronic forms after you watch this video. Once you have submitted the forms, call the office you prefer for an appointment. Thank you for tuning in to our online seminar. If you have any questions, please call one of our offices. We look forward to hearing from you.